So in the interest of time, we'll go ahead and get this satellite symposium on barostimulation started. I think you'll find the next hour to be incredibly interesting and rewarding, and will provide some knowledge to you that will be useful in your clinical practice. I'm Bill Abraham from The Ohio State University. I'm joined by Michael Bohm, who is my co-chair for this session, and we've got a wonderful faculty to set the stage and to present you new and exciting data on barostimulation or Baroreflex Activation Therapy as a treatment for heart failure. Let's see, can I have my slides up? How do I do this? You gonna take care of it? Okay. Yeah, the slides are just by way of a brief introduction. If we can go to the next slide, there we go. Now let's go back one slide, and I'll just introduce our faculty to you. Murat Fudim from Duke University, Johan Lindenfeld from Vanderbilt University, and Fayez Zanad from the University of Lorraine. And we'll have a panel discussion following their three presentations. This is a CME accredited session. There'll be a little QR code that you can scan in order to get to the evaluation and CME accreditation form. Murat, did you lose this? There you go. All right, well, let's get right to it. I'd like to introduce Murat Fudim, who will talk a bit about autonomic dysfunction in HFrEF patients.
Thank you. Thank you for the introduction. I'll just jump right into it. I was tasked by talking about autonomic dysfunction. Not something we think about every day, yet we have now dedicated therapies to target autonomic dysfunction. So I'll start by the mandatory slide to review the autonomic nervous system in the body, which really maintains all the functions you don't think about it. Eating, sleeping, blood pressure, heart rate, all of these things are regulated by reflex loops. And the two major systems here are the parasympathetic, that's the rest and digest system, and the sympathetic, the fight or flight system. The baroreflex, the arterial baroreflex specifically, which is located in the carotid arteries anatomically, but also a little bit in the aortic arch, is one of the key mechanisms to maintain blood pressure and heart rate in the human being with daily activities such as exercise. If you want to stand up and your blood pressure to maintain stable, that's the arterial baroreflex that allows us to maintain blood pressure and heart rate. So it's vital. Yet in heart failure, it's exactly that baroreflex that have been demonstrated for decades now to be dysregulated. And specifically what it means is that the baroreflex sensitivity, which I'll go over in a few minutes, baroreflex sensitivity is downregulated. That reflex is no longer as sensitive to changes in its environment as it is supposed to be. As a result, the sympathetic tone is high, the parasympathetic tone is down, and it has been strongly linked to worsening heart failure and heart failure symptoms, and I will demonstrate in the next few slides. So as I hopefully will demonstrate in the next few slides, and I won't be able to pack 50, 60, 70 years of research into a 10-minute presentation, but I will give you some of the high points. We do know that in heart failure, there's a strong association with a high sympathetic tone. You truly have high neurohormonal imbalance, so you have a lot of vasoconstrictor hormones, a lot of stress hormones floating around. It's associated with high filling pressures, worsening kidney function, and that then really translates to worsening clinical outcomes. That is pretty well established. So what is baroreflex sensitivity? So here's a thought experiment. If you to apply positive pressure on your carotid arteries, you trick the baroreflex to think that there's high pressure in the system, the result will be that your blood pressure drops. So now we can draw a curve that as the more pressure you apply, the lower your blood pressure gets, and that speaks to the sensitivity of the system. There's a way to just dial it in with a special technology. And you can do the reverse. You can give vasodilators, and you will see how the body tries to overcompensate and vasoconstrict and increase the heart rate in response. That's all baroreflex. In heart failure, the baroreflex curve is flatter. That's a solid black curve. If you now extrapolate it and use it, show it in the bar graphs, you see that compared to controls, heart failure patients, or here CHF, has low baroreflex sensitivity. By the way, that's true for heart failure preserved, but also heart failure with reduced ejection fraction. But the majority of the data will be shown for heart failure with reduced ejection fraction. So now if you match up baroreflex sensitivity, lower is worse, with symptoms, you see that higher symptom burden is associated with greater baroreflex insensitivity. So the baroreflex is less sensitive the higher your NYHA scale is. But then if you take it to the next step and you say, well, what is the association of actual outcomes? And here we're talking about survival, not even heart failure hospitalization, actual death. You see that CV mortality is significantly higher the lower your sensitivities. Well, is this an association? What's the chicken? What's the egg? Well, that we can't give you for sure an answer to, but we do know that if you stimulate the parasympathetic nerves of the baroreflex that sit in the neck, they're innervated by the vagal and the glossopharyngeal nerves, so cranial nerve 9 and 10 from your med school days. These are the ones that if you stimulate them, on the right side you see that you can decrease the sympathetic tone. It can be sustained. This is human data and can be sustained for 6 months. That's using the Barostim technology. But at the same time, if you to measure baroreflex sensitivity over time, that's the left figure, you will increase baroreflex sensitivity over time and maintain it. It actually increases with time. So there seems to be some form of learning. So we do know that it's associated with outcomes, and we can reverse that process, at least on that electrical level, and then feeding back to the brain, because this is a purely afferent reflex that gets integrated in the brain and then lowers the sympathetic tone on the back end. So to demonstrate it to you in a sort of more visual aspect, so this was initially tested actually in hypertensive patients. Hypertensive patients are known to have high blood pressure. And here, when you turn on the device here in dark on, you see that the blood pressure on top drops immediately within seconds, and the sympathetic tone measured via muscle sympathetic nerve activity, MSNA, in the perineal nerve, not a friendly procedure to do to the patient, so we're not doing it on a regular basis. Sympathetic tone goes down within seconds, blood pressure goes down. You turn the device off, blood pressure goes up, sympathetic tone goes up. So it's really an on-off phenomenon. It doesn't always work like that fast in patients, but it tends to be within hours to days that you actually see those acute effects. So now, is this a novel concept to intervene with the autonomic nervous system? No. As a matter of fact, one of the earliest device-based strategies to be tested for cardiovascular conditions was by Eugene Braunwald here in the middle, but the lady on the left is Nina Braunwald. This is actually deceased first wife. She was a surgeon. She did actually the implants of what was the earliest form of baroreflex stimulation therapy back in the 60s. And back then it was an implantable device, well beyond where actually pacemakers. They already were doing external pacemakers for the baroreflex. And here you see in the middle the carotid sinus circle and right. That's the little nerve that comes up from this. This is the carotid sinus is where that nerve patch is placed for the baroreflex stimulation therapy. So what does the historic literature teach us? Because they realized back in the 60s that this might be a viable concept. So they've done it for patients with refractory angina. And what they found is that if you give it to people with refractory angina, some of them might have been heart failure patients, hypertensive patients, you didn't have many treatments back then, is that by stimulating those nerves, you were able to see acute reductions in heart rate and blood pressure with a symptomatic improvement if you actually exercise those patients repeatedly. So this, of course, was abandoned in the 1960s. It was a relatively morbid procedure back then. They then started getting access to medication therapy, and so that fell out of favor till you'll hear in the next sessions, and by the next speakers, we came then, to the early 2000s where we developed a new novel implantable technology. Okay, to summarize, I hopefully demonstrated to you that in heart failure, baroreflex sensitivity is down, sympathetic tone is up, hormones are elevated, so you can certainly reverse that. And I did not show you impacts on neurohormonal levels. There are data on that in animals and humans. I did not show you the impact on kidney function. There are animal data on that. So those neurohormonal imbalance does get restored to some degree, certainly not perfect, but that is the mechanism of action. And the next speakers will then hopefully demonstrate to you how that translates to clinical findings and clinical endpoints. Thank you very much for your attention. And we will do questions at the end, right? Questions at the end.
So it's a great pleasure now to announce John Lindenfeld, Challenges and Unmet Needs in Guideline-Directed Medical Therapies for Heart Failure with Reduced Ejection Fraction.
We have an equipment malfunction. Hold on just 1 second.
There's no even slide here.
All right, great. Thank you very much. Well, that is a terrific introduction, and it's a pleasure to be here. My job today is to talk about unmet needs in heart failure, which I know you've heard some at this meeting, and then talk about the preliminary data we have that led to the approval of Baroreflex Activation Therapy. And I'll go through these pretty quickly, but these are the things I'd like to tell you about the unmet needs. That heart failure morbidity and mortality remain high despite guideline-directed medical therapy or GDMT. Exercise capacity remains poor despite maximally tolerated GDMT, and it doesn't change much with guideline-directed medical therapy. Quality of life is also poor and doesn't change much with GDMT. And patient tolerance and compliance with GDMT is poor. But in heart failure with reduced EF or HFrEF, we have made remarkable gains. So here I've just summarized to you the percent reduction in mortality with various therapies, starting with ACE, ARBs, sacubitril, valsartan, beta blockers, MRA. I'm just reading across hydralazine, isodil, SGLT2 inhibitors. And those are remarkable reductions in mortality, about a 75% reduction. But there are some things, even though all this medical therapy improves in heart failure, that it can't do or do completely. And those things are replaced by devices, and devices that we now already use on a routine basis. The use of devices in heart failure is not strange to us. For example, we've been using defibrillators and cardiac resynchronization therapy for a number of years, and now MitraClip, or transcatheter edge-to-edge repair for moderately severe secondary mitral regurgitation is standard. So device therapy is not a surprise to us. And I think we now need to think of heart failure as, especially heart failure with reduced EF, as this intersection between medical therapy and devices, and expand that algorithm. But despite all of these medical and device therapies, and when we say GDMT, for example, when we said optimally titrated GDMT in the COAP trial, we meant guideline-directed medical and indicated device therapy. So it's both. But despite all of those applied appropriately, the residual morbidity and mortality remains high. This is from the latest SGLT2 trial in reduced EF, and you see that in the empagliflozin arm, there was still about a 25% reduction over 3 years, a 25% incidence of heart failure hospitalizations and mortality. So there is a lot yet to address in heart failure with reduced ejection fraction. And just to briefly summarize, this is a complex slide which Greg Lewis summarized, but what you see here are medications in green, a various number of inotropes in yellow, and then CRT in the blue. And you see that with the exception of CRT, this is the percentage increase in exercise capacity, however it was measured, that changes to the exercise capacity with medications are not that great. MRAs being the most, which is a little bit, I think, surprising to many of us. Yes, there is an increase in exercise capacity with inotropes, but probably at the expense of mortality. And then CRT, certainly more than with medications. And with medications, quality of life doesn't change much. So here I've summarized for you in green the intervention group, the medical group, SGLT2, control in yellow, and the difference in blue. And you can see these are KCCQ points, and they're very small. There was less reduction on the far right there with the sacubitril valsartan, but still the changes in quality of life, the mean KCCQ score is small. So we don't have nearly the improvement we would like to see in these patients who remain with a poor quality of life. And in addition, the long-term tolerance, up-titration, and discontinuation of guideline-directed medical therapy is high. This just recently, a very nice published study, showed you in dark green the full dose of the medication, and that's pretty easy with dapagliflozin because there's one dose really. But what you see in red, let's look at sacubitril valsartan, next red up here, and you see in red the discontinued treatment. In the light tan color, you see low dose, it stays at low dose. In the light green, you see that it stays at intermediate dose, and only in the dark green is the maximally tolerated dose, the maximum dose of what we expect. So you can see that with sacubitril valsartan, ACE inhibitors, ARBs, beta blockers, MRAs, very few are on the maximally tolerated dose, and many have the drugs discontinued over the course of time for a number of reasons. So there are opportunities here. Morbidity and mortality remains high despite guideline-directed medical and device therapy. Exercise capacity remains poor and doesn't change much with medical therapy. Quality of life is poor and doesn't change much, and patient tolerance and compliance with GDMT is poor. So could devices help address some of these? There are a lot of things, as I've said, that medications can't do or do completely. Treat ventricular fibrillation, resynchronize the heart. Medications can improve dyssynchrony, but not completely. And then, of course, transcatheter edge-to-edge repair. Mitral regurgitation we know can improve enormously in heart failure with reduced EF, but not completely, and there's still a large number of patients for whom edge-to-edge repair is valuable. So here's just where we are. In the dark blue here, I've shown you for patients with a narrow QRS and a wide QRS. For a wide QRS, we have CRT in about 15%, maybe as many as 30, but probably more like 15% of patients. And ICD and CRT, you'll see over there in the wide QRS. And then we have two devices to date, Baroreflex Activation Therapy, BAT, or cardiac contractility modulation that improves symptoms. And they both have 6-month randomized trial, and I will show you that for BAT today. And then, of course, we have MitraClip for secondary severe MR with an EF of 20 to 50%. So in there, for symptomatic improvement, are BAT and CCM, and I'll go on and talk to you about Baroreflex Activation Therapy for just a minute. So Dr. Fadim has already very well gone over the mechanism here. We know that in heart failure, both heart failure with preserved and reduced EF, that there's autonomic dysfunction, there's a decrease in parasympathetic activity and an increase in sympathetic activity, and those things can affect heart rate and remodeling and diuresis and vasodilation and the blood pressure. So we would like to optimize all of those things. And medical therapy can do that a bit as the heart remodels and improves, but not completely. I would also point out to you that this activation therapy does have one distinct advantage, and that is it's entirely extravascular. This right now is a very simple procedure done by the vascular surgeons. They say that surgery itself takes about 10 minutes to place the device over the carotid sinus, but it is extravascular. So, Baroreflex Activation Therapy was the first therapy both designed under the FDA breakthrough policy and approved under that policy. CCM was approved under that policy but not designed. And the idea of the breakthrough devices policy by the FDA was to get drugs to market on less than morbidity and mortality, to get some use and get them out there faster, and then go on and do morbidity and mortality. So that's exactly how the study was designed. And it was a 6-month study that randomized patients with HFrEF and New York Heart Association Class 3 heart failure in 1-to-1 randomization to optimal medical management, including appropriate device management, but in patients who were not candidates for CRT. And then the Barostim plus the same medical management. And the endpoints for this were 3 intermediate endpoints: BNP, 6-minute hall walk, and quality of life as assessed by the KCCQ score. And I would point out to you that to be positive, this trial had to have statistical significance of all 3 of those endpoints. Not just one, but all 3. So let me show you the results. And these results are the basis for which the baroreceptor activation therapy or baroreflex activation therapy was approved by the FDA on these intermediate endpoints. Exercise capacity at 6 months improved 60 meters. You can see the difference in blue. So the BAT group went up, the control group went down slightly, as we often see in heart failure studies. 60-meter difference. Quality of life, a 14-point difference favoring baroreflex activation therapy. Now, this is the Minnesota Living with Heart Failure, not the KCCQ, so it's better as the number goes down. So minus 14 is the same as positive 14 in the KCCQ. So a highly statistically significant difference. New York Heart Association class also improved, 34% improvement, improved at least by 1 New York Heart Association class. And BNP, there was a 25% reduction in BNP. And we know that from Paradigm, for example, sacubitril valsartan, heart failure with reduced EF study, that as little as a 10% change predicted a change in mortality. So these were pretty highly significant intermediate endpoints, the basis for which baroreflex activation therapy was approved. Now that study goes on in the breakthrough design for morbidity and mortality. And let me just show you first, all of these endpoints were consistent across all subgroups. So whether you looked at atrial fibrillation, yes or no, this is the Minnesota Living with Heart Failure, so down is a benefit, and in blue is the difference in the control and treatment group. You see whether there was atrial fibrillation, whether the ejection fraction was 25 to 35 or less than 25%, and whether it was women or men. All of these groups had an improvement in Minnesota Living with Heart Failure. The same is true for 6-minute hall walk. Here we see again in blue the difference, and you could see that there's an improvement with or without atrial fib in the low ejection fraction range, which is the only less than 25% approved device in this ejection fraction range, other than CRT and ICD, and then also in women. And amazingly, the benefit here in women was really quite remarkable for quality of life and 6-minute hall walk. So in conclusion, despite contemporary GDMT and device therapy, there are significant needs that remain because exercise capacity and quality of life are poor, mortality and heart failure morbidity remain high, and patient tolerance of symptoms with GDMT is poor. Baroreflex activation therapy uniquely works to rebalance the sympathetic and parasympathetic branches of the autonomic nervous system. Baroreflex activation therapy was approved by the FDA in 2019 based on safety and strong and consistent improvements in BNP, New York Heart Association class, quality of life, and 6-minute hall walk, all of them. This was a novel design, the first breakthrough design. There are no randomized long-term data on symptomatic improvements from device therapy for patients with a narrow QRS until now, and you're going to hear about that next. Thank you very much.
Thank you, Joanne. Let's move on to the last of our 3 talks, and then we're going to have plenty of time for our panel discussion. Faiz Anad will update us on the most recent, really breaking results from the long-term safety and outcomes phase of the BEAT-HF trial.
Thank you so much, Joanne, for setting the field so nicely. And this is a very unusual situation whereby this is the first ever trial you may have seen with this new paradigm from the FDA, whereby you have this interim look and 2-phase with progressing seamlessly from what you have heard to mortality and morbidity. And I'm going to show you the result extension to morbidity mortality phase in the same trial. So basically this is some sort of same trial on behalf of the steering committee, and we have many of them here in this room. These results have been presented at THT in Boston by Mike Zile, and I am hopefully you will hear from me for the first time here. So you have heard about the rationale and design of this trial, and this results that I'm sharing today is the extension of the trial with many more patients, and throughout this expedited access pathway post-approval. Therefore, the device was available in the United States, but we had to keep the patient in, the same that you have heard from earlier on, and add additional patients. And these are the inclusion criteria. And you can see one typical difference here. The NT-proBNP was below 1,600 because, as per agreement with the FDA, post this early phase that you've heard, we found that patients above 1,600 didn't do so well with the therapy, so we've decided with the FDA to focus on only patients with NT-proBNP below 1,600 and to add more of these patients with this inclusion criteria. So this is the diagram, first phase, pre-market, you have heard about it, and the extension, which is the right-hand side, adding fewer more patients, and by the end of the day, the full group of the first cohort and second cohort of 163 versus 160. This mean seemed to be small numbers, but this was a high-risk category of patient, and we have accumulated more than 300 primary events, which is a sizable number in terms of statistics in outcome trials. And what is very important is the duration of follow-up, and you can see, indeed, there is a median of 3.6 years patient duration of follow-up in order to accrue the needed number of events. The baseline characteristics were not so different from what you have seen earlier because we have added a few more patients And as a consequence of the inclusion criteria of BNP below 1600, you can see the NT-proBNP wasn't so high, but all patients were class 3 New York had, almost 95%, and the event rate was really high. This means we are having here the most serious and severe patient. You can see the history and typical of a serious severe heart failure with reduced ejection fraction patient population. They were very well optimally treated. The trial was conducted before the advent of SGLT2 inhibitors, so no wonder there was nobody on SGLT2 inhibitor, or almost. But look at the ICD, almost 80% had ICDs. This means you shouldn't really expect much sudden cardiac death in this trial because they are very well protected against sudden death. Otherwise, the background medical therapy was great. Now, these are the study endpoints which were negotiated with the FDA. The primary endpoint was cardiovascular mortality and heart failure hospitalization, the very classical, and we aimed at 320 such events. And of course, we have the breakdown of the component of this composite event, the CV mortality, and we have explored a number of other endpoints. In clinical trials, we always struggle what to do with patients who progress to LVAD or what to do with patients who progress to transplant. Some analysis, and we elected to do so, lump this together with cardiovascular death, and we'll show you the result of this CV mortality or equivalent of mortality. And we have also looked at the subcomponent of heart failure morbidity, which is not only the classical heart failure hospitalization, but also the non-elective heart failure hospitalization and heart failure emergency room visits. We also have used a modern way to look at the entirety of the event and the outcome, which is the win ratio, using hierarchical composite endpoints, and I'll get to that in a couple of minutes explaining further. But the value of this win ratio is it takes into account morbidity and mortality, but also disability, safety, and quality of life, and exercise capacity, and functional status, the totality of evidence. So this is the primary endpoint. You can see the curves almost did not diverge much. They seem to be diverging early on, but then they came closer later on. And as you may expect, the trial was neutral. There was no statistically significant difference between BAT and control on these hard endpoints of primary composite endpoint, CV death, and heart failure hospitalization. Then we have used this hierarchical composite using win ratio. And typically, the value of this win ratio is that every single patient in the trial contributes. You may not know that in the survival endpoints, only patients who had an event contributed to the final result. Patients who go throughout all the trial not having had heart failure hospitalization or CV death do not contribute to the result. So, and yet they may feel better, having better quality of life or worse. And this is the value of this hierarchical composite using ratio, the win ratio analysis. Every single patient contributes to the result. And you can see here, indeed, that hierarchically we will consider CV death first if the pairs of patients, because every single patient is compared to the other equivalent in the control arm, and if in the pair of patients, one of the patients dies, then there is a loser and a winner, right? But if both of them survive, then we'll go to the next endpoint, which is whether they had a transplant or an LVAD. Same thing, winner or loser. If they don't, they are still alive and haven't had no LVAD, no transplant, we will go to heart failure hospitalization and down the road until we hit quality of life in all survivors, patients who are not hospitalized, but still are there, and they contribute with the event just by how much they feel better. And putting all this together, we have a ratio, which is called the win ratio, between the total of number of wins that Baroreflex stimulation got over the total number of wins for control. So it looks like this. This is the typical diagram of the win ratio. In red, you have the BAT therapy, and then the control is in blue. And you can see that the bar of BAT was larger, and expressed in win ratio is 1.26, and it may have a hazard ratio and also p-value, which was here significant of p0.004. I hope you get this important new way of looking at the results, which has now been applied in multiple heart failure trials. And you can see the components of this win ratio, whether it's mortality, morbidity, quality of life, the other contributors. You can see that most of the time the red bars are larger than the blue bars, and you can see how much any of the components contributed to the last event, and this you can see sizably every component contributed to the result, and this is very important. Now, if you go to the sensitivity analysis I have shared with you, which is the all-cause mortality and heart failure morbidity and quality of life extended to enroll the LVAD and the transplantation, you see the same tendency of 1.27 win ratio, 27% more patients on BAT1 on this computation, and this was statistically significant. And now we have also looked at the data, and these all are the secondary analyses. This is what we call clinical stability analysis. How many patients worsened or stayed alike or just improved, and the improvement worsening take into account the death, hospitalization, New York Heart Association, and you can see at the end of the day there are many more patients who improved on the BAT therapy, fewer patients stayed the same, and fewer patients worsened when compared to placebo. So all this goes in the right same directions. Now, freedom from all-cause death, LVAD, and transplant, we have created this new composite. You can see that this was marginally statistically significant, 0.054. I take it as very encouraging because the hazard ratio was 0.6. This means there is a sizable result, although it was marginally statistically significant. And the next slide shows you the rest of the softer endpoint. And the softer endpoint was the easy game to show. This is very simple, consistent with the first phase that you have heard from Joanne. Everything goes in the right direction in terms of quality of life. BAT was much better than control. In terms of 6-minute walk test, the improvement was much larger in the BAT group, and so was the improvement in New York Heart Association. So anything on this quality of life evaluation went in the right direction in favor of BAT. So putting all this together, this is a thick sandwiches of layer of results. You can see anything at the bottom, which are this safety and quality of life, exercise capacity, functional status, everything is the right direction, statistically significantly so. BAT is much superior to control. The middle is all-cause mortality and extended to be used within the win ratio, and you can see it's all also getting in the right direction, statistically significantly so. And the upper is the hard endpoint, morbidity, mortality, CV death, and heart failure hospitalization. And you can see the confidence interval was really large, and I will show you some of the results of this, certainly because the number of events were not that high, but there are other interactions, and I will come to that later. Now, in terms of safety, I could have started with this. Safety was outstanding. The device was surgically implanted in an outpatient procedure. It is totally extravascular. We don't need a vascular surgeon. The electrode is just applied on the baroreceptors, and the safety, whether during implantation or after, was excellent. Very few cases, almost none, with inflammation or, just healing of the wound. And we have looked at the data because, of course, this trial was conducted during the pandemic. So we have looked, as expected, and as anyone would have expected, and was the FDA will mandate to look at that, the interaction of COVID. And there are funny stories, and you have heard about this COVID interaction with many other trials. So if you see the cumulative event rate here, you have seen this slide before, but now this is expanded to have the heart failure morbidity, hospitalization before, during lockdown, and after. Funny things happened. During COVID, the control group stayed home and felt well. I did not get to the hospital. Of course, the patient on BAT, maybe because they felt they are less vulnerable or something, they kept being treated like usual and get to the hospital like usual. And there is a crossing of this curve. It's mysterious. We are digging into this, trying to find out why did it so, but you can see that stopping the trial before COVID, the trial would have been positive in morbidity mortality. So this is a funny interaction. We are looking into more detail and sharing this result of the FDA because they have developed ways to look at interaction with the COVID. Many trials expanded during the COVID area had faced this type of issue. So looking into this with the FDA. And the main confounders are potentially many. You can see here some hypotheses, and it is only speculation at the time being, but it's fair enough that we share the results as they are with you, and I leave you to guess what happened. We are still guessing. And finally, if you take this COVID interaction back in the figure that I've shared with you, the only change is the top layer, which is primary endpoint, and then you can see the confidence interval. If you exclude patient during and post-COVID, the confidence interval is so smaller, and then, of course, you may see a tendency to a positive trial. And, of course, I can humbly submit to you that this is kind of speculation, and we need to look at the totality of evidence with the FDA, see how to do with that. But still, there is lots to take home here. BIT did not, even though it did not result in statistically significantly difference in the primary composite endpoint of CV death and mortality, the freedom from all-cause death plus LVAD plus heart failure transplantation was marginally significantly higher in the BAT group, and the hierarchical composite endpoint of CV death, heart transplant, LVAD, heart failure hospitalization, quality of life, taking into account every single patient, analyzed with the win ratio, was significantly improved in the BAT group. Short-term significant symptomatic improvement that has been shown by Joanne were maintained long-term, and in their extent and in their individual magnitude effect. And the excellent short-term safety was also maintained long-term. So taken together, the results obtained during the long-term post-market phase of the BEAT-HF trial indicated that BAT was safe and had durable clinical benefit in patients with HFrEF. As you may know, the ACC-AHA have got this device already in their recommendation for improving quality of life and signs and symptoms, and the FDA has already approved on the result that had been shared by Joanne. Now these extension results are being submitted to the FDA, and we look how impactful this will be, including in the next set of guidelines. Thank you so much for your attention.
Thank you, Fayez, for this great talk. So are there any questions from the floor? Please go to the microphones. Oh, we have some?
Yeah, we've got a couple of questions that have come in via messaging. The first was, would the selection of patients according to the baseline autonomic imbalance, perhaps assessed using baroreflex sensitivity or heart rate variability analyses, have yielded more positive findings? So should those factors be considered in patient selection? What do you think?
Well, you've seen the color of the slides that I did. I showed you quite old physiology. We don't do any form of standardized baroreflex testing right now. The recording of autonomic tests or the autonomic function is not that easy. We have a number of ways to look at heart rate variability, a relatively dirty signal. You could technically do baroreflex testing on all the patients, but most centers would not be able to do that. There's no easy way to test for it. So surprise, surprise, the indication granted on BEAT-HF was quite broad, LVF of 35 and less, and you just had to be symptomatic on top of it. So I don't have a perfect answer whether, I think would have yielded a better outcome. Probably, if you would have selected for patients that actually have a greater degree of autonomic imbalance, but to get to that would have not been that straightforward. But I'm, curious to see what other people think.
Yeah, I think we just don't have a really good way to determine that, and we do have some ways, but they're not standard operating procedures. So we've had a great way in no enrollments. But I think it's fair to say that virtually everyone with New York Heart Association class heart failure has autonomic imbalance, or a fairly substantial amount. So I think it's true that if we had picked out more, we would potentially have better results, but I think it's a pretty standard feature of HFrEF in class 3.
Yeah, Faiz, you've been engaged in a lot of neuromodulation trials. What do you think?
Yeah, that's the issue of all these therapy. Of course, we wish we could have a way to select the patient most likely to respond because they have a dysautonomy or a depression of the baroreflex. In addition, we would have liked to have metrics which would measure how much therapy is being delivered, whether we have resetted the baroreflex. Of course, we do some resetting during implantation, but that's once for all. We don't have metrics in order to know whether we are doing a dose-effect relationship. And therefore, it's one size fits all. We try to do the adaptation during implantation, and that may be the lesson for the future, maybe refining this therapy, finding out patients who are most likely to benefit, and in addition, finding out how much baroreceptor resetting we are doing with our device.
So Faiz, we discussed it a lot. Would the results be different when you do a sham control trial, beat HF?
Well, it's a good question. I am a PhD in pharmacology as being a cardiologist and being very much trained in clinical drug trials, right? And I'm discovering with Nectar HF, with vagal stimulation and a couple of other devices, certainly I've been involved into respiration in sleep apnea and this one, that the word of trials with devices is really different from the word of drug trials. And in a good way, because the FDA device section are much more, reflective and certainly creative in order to foster innovation. And they do accept ways to look at the data that I have shared with you today, which is the totality of evidence. They do accept to lump soft and hard outcomes. They do accept this interim analysis and approval based on only soft endpoints and provided we have this extension of outcome. So I am learning, and I learned the good lessons. I can assure that I have been kind of pesky during the steering committee meetings because of my background of drug trials. But by the end of the day, I'm really convinced that one way to go is to borrow and learn from the device trials in order to foster and create more innovations.
There is a question, please.
Yes, I noticed in the baseline data there were some patients with bradycardia, and I just wonder whether there was a safety issue in patients who may have, for other reasons, bradycardia. I understand that they all have potential for decrease in sensitivity, but if they have bradycardia, is there a safety issue?
There were not bradycardias, if I can remember. There might have been one, but of course this is an up-titratable therapy, so it goes every couple of weeks for a bit. So if you do get into, so you lower the heart rate at each therapy, and so you can avoid going too low, I think, in that setting.
It just that in the baseline characteristics there was some patients with bradycardia.
Yes, and bradycardia was not, there might have been one or two patients, but there were not a large number of patients for whom bradycardia was an adverse effect. Can I come back just for a second to the question about sham control, because it's a really interesting question. It's about what is a placebo effect, right? And I think everybody would like to know that. We'd love to have a way to measure it. But I think this was a very long trial. So you have to say over a period of the first 6 months, that's even would be long for a placebo effect. But several years is even longer. And the best data we have for that is in a study you did, Bill, one of the first CRT studies where there was a crossover study. And people were turned on and off, and they didn't know which they were. And it turned out it looked like the placebo effect. So both groups got a little better. Both the on and off got a little better. And then when they were switched, you could see the group that was on and went off went down like this. And the other group went up. And the same is true for cardiac contractility monitoring, where they did the exact same thing. So a crossover, all implanted, and then switched to 12 weeks. And so 12 weeks seems to be what we expect. We don't know that for sure, but that at least 2 trials that we have, that's what seems to be the placebo effect. And this was years longer than that. So it seems unlikely, but
Yeah, no, I agree, Joanne. Great observations. Now, we just talked a little bit about heart rate. There's a general question in here about effects on blood pressure, heart rate. I think part of the sort of neat thing of barostimulation is that it sends an afferent signal to the brain does the rebalancing, right? So in hypertensive subjects, Baroreflex Activation Therapy lowers blood pressure. In normotensive or hypotensive heart failure patients, it doesn't have an effect on blood pressure and generally doesn't have an effect to slow heart rate as well, which you'll see in more tachycardic patients or in the hypertensive patients as well. So it seems to do this rebalancing in a way that takes into account where you are in terms of blood pressure and heart rate. There's some other questions in the queue here. Interference with ICDs. I think that's been pretty well studied, and unless anyone has any other information, I don't think that there are any device-device interactions to be concerned about. Am I right about that?
you are.
Okay, thank you. Let's see. This is a really interesting question. I think it requires some speculation, but I'd love to hear your views on it, as would the audience. And the question is, does BAT open up the possibility to better uptitrate or optimize medical therapies? We tend to order things, drugs first, then devices, but many patients don't tolerate GDMT very well. You pointed that out quite well, Joanne. So do you think in that instance, turning to the device earlier might help us subsequently optimize GDMT?
Yeah, it's certainly a possibility. We didn't test that possibility. And you try to avoid too many uptitrations in the beginning of a study because if you uptitrate in the control group, that may be the benefit. But what we would say in the data that I presented to you that I didn't show was the control group, the medical group, had a much higher incidence of starting sacubitril valsartan than the BAT group, suggesting that, we don't know the reason for that, but suggesting that people were worried about them. And despite that, you still saw the benefits that were demonstrated.
And then from the clinical experience, we have seen patients and other providers I've talked to that the diuretic requirement tends to go down once your Baroreflex activation therapy is activated, like 4 weeks later. So I had patients where I actually withdrew diuretics over time. So is it because they are more sensitive to the drugs they have on board now with the drugs? So that's because there's some preliminary data from animals to suggest that you have better renal performance. And so I agree with the statement also that it does not affect the blood pressure. So as with time, the LVF and TPO-BNP improve, it does give more room to titrate medication. You just feel more certain about being able to do that.
So, Marat, is it the baroreceptor dysregulation, is it a target for therapy? So if you have a full therapy, does it change? There are very old data that the baroreflex is sodium, potassium, ATPase, and sensitive to digoxin.
Well, has that been tested for directly on the baroreflex, the digoxin?
Exactly,
Yeah.
but this is from 86.
Yeah, well, I think let's think about it. In HFrEF, the drugs that are all working and improving outcomes are all to some degree neuromodulatory drugs. So you could argue, why do you need any more neuromodulatory agents or therapies if we have such great drugs? Well, drugs have side effects. Drugs vasodilate organs you don't want to vasodilate, but at the end of the day, this is a targeted therapy. So I do think that it just layers on top of already what the other drugs, beta blockers, ACE, ARBs do.
Yeah, principally, it would be interesting whether you can change the dysregulation by drugs.
If you develop that, we'll talk about it.
It has been tested with conventional ones first.
Yeah.
Yeah. Faiz, you have a comment on that?
Yeah, I would like to get back to the discussion we had on soft endpoints and how much credit we can give to the quality of life, etc. And this is indeed different from what we see in the drug trial, double-blind and placebo-controlled, etc. It's really important that we understand the FDA mindset and the need to progress into this area. Certainly, the decision to allow the trial to go forward with morbidity and mortality based on early benefit on soft endpoint was open label and therefore could be open to bias. But what they accept, and we have published this, including with people from the FDA, by the way, that if the three endpoints, which is neurohormonal, NT-proBNP, quality of life, 6-minute walk test, all of them go in the same direction, this gives much more credit. Same direction. They call it congruence because it adds up to mechanistic plausibility. And then what Joanne has added is long-term. If these results are persistent over months, years, this would also give more credit. There is no way, they are still very open because this is open-blinded to bias, but at least to decrease the level of bias, the congruence between all these elements and the long-term sustainability is good. But because of this, the FDA wanted to have this new type of trial that we are sharing with you, the first of them in the cardiovascular devices, whereby after approving based on soft endpoint, they would extend the morbidity mortality as I've shown here today. So it is taking all this together and using more sophisticated statistics, including Bayesian statistics, not frequencies, which is only P005, which if you are above P005, you are dead. If you are below, you may make it. But they say there is no reason to lose the whole wealth of data we are collecting together, and let's look at them, including using Bayesian approach. And this helps with being more creative and certainly helps putting forward more innovation in the device world. We have had a confrontation between the device and drug people discussing whether we can borrow from the device people within the drug people. There is a way forward, especially in the rare, orphan cardiomyopathy and many of these diseases where we are using the same kind of approach. So we really need to learn from each one, the drug and devices, and have the best of both worlds for the benefit of our patients.
Well, let me ask a question. I'd like each of the panel members to give an opinion on, and tell us today, who in your clinical practice would you recommend for barostimulation? I think it's really important for the audience to begin to understand patient selection here. Murat, you want to start?
Well, the people that we refer ongoing symptomatic heart failure, if we did GDMT titration for, let's say, 6 months, ICD is in place, LVF remains low, CRT has been contemplated, and it's not applicable to the patient, we are obliged, in the patient's interest, to offer additional therapies. And since we have in our center the availability to actually refer for barostimulation therapy, we offer the patient with symptomatic class 3 heart failure the ability to do interventional procedure, which is here barostimulation, explaining the pros and cons, the fact that it's invasive, but then demonstrating the data. I mean, to be honest, and I've heard comments before like, well, that seems so invasive. Why not just take pills? Well, they have taken the pills. They have failed. That's why they're coming to us and still symptomatic. We have to put ourselves in the shoes of symptomatic patients. Their symptoms prevent them to go to the mailbox, to go shopping, to go to the bank. So I think we need to at least offer the patient the opportunity and let them decide as opposed to us deciding on their behalf. And patients tend to accept that, and that's why implants are going on right now, because patients choose that path.
Yeah, I think that this kind of therapy is for patients with heart failure and reduced ejection fraction who meet the qualifications here in terminal proBNP, who you optimize medical therapy as best you can, and they remain significantly symptomatic and want more. It's not for the person who doesn't want more, maybe who's in a wheelchair, but for the person who wants a better quality of life and wants to be able to walk farther. I think this is who you offer it to.
Yes, well, you said it all this morning in the other session, Bill. You said, don't forget devices, because heart failure therapy are drugs and devices, and we really are doing a bad job implementing drug therapy, but even worse job implementing device therapy. And again, we need to have both of best words, and what you have heard this morning is that we do have devices which are effective in patients where you have done your job, having them on optimal therapy. You have seen the residual risk shared by Joanne. there is a huge number of events occurring, even in patients who are on super optimal drug therapy. In these cases, yes, please consider devices. There are a couple of them which are effective now. And of course, I know that there are market access issues, pricing, etc., but this all need to be worked out. And we will be working with you in order to go for this direction, in order to get our patients on best possible therapy, which is drugs and devices.
So, Fayez, is there a sub-analysis, secondary analysis according to severity of heart failure?
We have looked at the number of subgroups, but didn't want to go much into this because the trial was not very large. We get into more modeling in the data with subgroup analysis, and the patients were all severe enough. I had got the recent event rate, which is 30% event rate, heart failure, hospitalization, mortality. So these are very serious patients. We didn't see any significant subgroup interaction, but with the weakness of subgroups in small trials. But nothing was really visible.
Are there any more questions? This is not the case. We have nothing in the chat. So thank you very much for the excellent presentations here. And I would like to remind you to fill the evaluation forms that we can improve the meeting any more further. Thank you very much for your attendance and a nice conference.